Welcome everyone, and welcome to whoever's listening to us out there. Thank you for joining the Young Professional Board's virtual panel tonight for Gateway Foundation with Drs. Roueen Rafeyan and Sarpolis, who are our Chief Medical Officer and just one of our best, don't tell the other ones, Medical Director. And tonight we hope that whoever's here in person and then also listening out there will learn some information about a very important topic, which is substance use and addictions and addiction medicine and medication-assisted recovery. But also we'll learn a little bit about Gateway and why it's so important to have these conversations. So it's nice to have 20 people here, but if you think about how many people died last year of an overdose, it's 108,000. Someone said that's like Philly United Center several times over. So this is just a small group, but the more that we can educate people about why it's important to talk about substance use as a disease of the brain, it will end the stigma and will allow people to come to treatment. So over 22 million people in the US suffers from some kind of substance use disorder. Only about 11% actually ever go to treatment. Part of it is access, there's not enough access, but a big part of it is stigma. So my role here tonight as part of the executive leadership for Gateway is to welcome all of you. I'm Dr. Teresa Garate, and I'm the, Senior Vice President of something. And even though I'm Dr. Teresa Garate, I'm not an MD, I'm a FID, so don't ask me anything medical. But my role here tonight is just to engage in a conversation with the two gentlemen, esteemed doctors, and then we're going to spend about 45 minutes, and everyone who's here is going to get a little demonstration on how to use Narcan. Does everybody know what Narcan is?
Yep.
Everyone here is nodding, so that's good at home, nod too. But a lot of people don't know how to use it and maybe are scared of it. Carolina and I went to a fair a couple of years ago, a farmer's market, and we tried to give it to somebody, and people were like, "Oh, we don't need that." And we were like, "Really? Oh no, we don't need that." So we want to try to end the stigma around that as well, and make sure that everyone knows how to use it. And if you're here, you'll leave with a dose of Narcan to use if you need to. Okay. Did I miss anything, did you? All right, great. All right, well, thank you both for being with us.
It's a pleasure to be here, and thank you for organizing it. Thank you, Deidre, for really pulling all of us together. I would like to thank our MKB Architects for allowing us to have this panel over here tonight, so thank you.
So why don't we start, first of all, with both of you introducing yourselves. What kind of doctors are you? What's your specialty? And then most importantly, why you've made it your life's mission or your professional mission to work in this field. So,
I'll start. So, I kind of always knew I wanted to be a doctor. I didn't know what kind of doctor I wanted to be. I got out of medical school. I was at Grant Hospital, which is now closed, as a teaching attending there. Kind of interestingly enough, while I was at Grant, I was kind of being recruited to run their substance abuse program there, which I said, I don't want to do that, nonsense. And so something kept pulling me back to this field here. So went off on my career, was in practice up in Evanston for years, basically a primary care physician. So I trained as an internist. And one of my patients asked me to start performing some work for Gateway. So one of our outpatient clinics, also now closed, it was in Wrigleyville. So I started working there, and the job just kept evolving. And eventually I was the medical director down at the West Side. And 5 years ago, I became full-time with Gateway, and I'm covering both the Lake Villa and the West Side or Independence site. That's been just about 5 years now. I think it's 5 years in September. I'm kind of attracted to underserved populations. Okay? Even when I was in practice up in Evanston, it was difficult, but trying to take care of people that are on underinsured Medicaid and such, and it just didn't work very well in that environment. The problem is always trying to get specialists and the other people in the medical community to see those patients that are really underinsured. And so when I got this opportunity with Gateway, it was perfect. They serve a wide variety of patients from lack of insurance to Medicaid to full insurance. It's really the full scope. And I just kind of love what I'm doing at this point. It's a very rewarding job. It's a difficult population to take care of. But that's what's great about Gateway is they have the resources and the wraparound, the psychiatry, the MAT services, they kind of offer the full scope of services, and that's what this population really needs.
Thank you, Dr. Sarpolis. Dr. Rafeyan?
So Dr. Sarpolis is being a little bit modest. He does actually oversee as the medical director for two of our busiest, largest facilities like Villa and Chicago Independence. So very, very busy. And as he shared with you, he loves what he does. And without love, you really cannot do this work, the amount of work that it requires. My background, I'm a psychiatrist. I always knew I wanted to be a physician, same thing. Finished my education, residency training in psychiatry at UIC. An interesting fact that I realized, by the end of our residency training, we could identify a patient who had substance abuse issues or alcoholism. We knew we had to refer him to treatment, but this is the paucity in the education and lack of the education, even for a psychiatric residency. I had no idea what happens in treatment. How do you treat these guys? To some degree, because of, I'm going to say, ignorance in just general medical community, of lack of ability to deal with substance abuse, these patients are overlooked. No one wanted to deal with them. No one still doesn't want to deal with them. There's a lot of judgment that is passed on. So their needs, their medical needs, their psychiatric needs really fall short. They don't get it. So that was my attraction towards substance use treatments and pursuing them further. Rush University was starting their Rush Behavioral Health, and they asked me to join them, and I did. And that was my gateway into my career into substance treatment and addiction medicine. I do both. I do psychiatry and addiction medicine. I've been with Gateway for about 6 years now, and it's been very rewarding. Very rewarding to be at this position I'm in today, because I have been able to bring protocols, evidence-based medicine, and improve the outcomes. And again, the attracting part about working for Gateway is it is non-for-profit, and that's what was the part that made me make a decision. Unlike many other entities that are profit-oriented, here the goal was outcomes and patient safety. And I think we all, as physicians, we want to do that. We want to take care of our patients in a safe way, rather than an assembly line and missing.
Thank you. Yeah, well, we'll take your money too, so not to worry. No mission, no margin. No margin, no mission. That's the way.
You still have to stay alive.
That's right. That's right. It's interesting because I think most people understand that it's very difficult to find psychiatrists, but it's really difficult to find psychiatrists that are also addictionologists, right? So we are very lucky to have the medical staff that we do, because it's very challenging. So, okay. So Dr. Rafeyan, why don't you start off by setting the context of this field, right? So how, first of all, how do we know that addictions really are a disease of the brain? How did the treatment of these diseases begin? And why is it that we treat people now in the day and age that we're in, really as with addiction medicine, not just with 12-step, not just with support groups? So can you set the context for us a little bit?
Sure. So let me kind of go back and give everyone a little story.
We only have 20.
Let me see if I can summarize 100 years in 5 minutes. First, the first question is addiction. Where does it come from? Why? Why some of us get addicted, some of us don't? Look back to thousands of years, addiction has been part of human culture. So the question is why? Let me go over some like simple facts about what addiction is. If we use or do anything that feels good, doesn't it? Feels good. So if it really feels good, you may want to do it more. And the common neurotransmitter in the brain, I call it the feel-good neurotransmitter, is dopamine. For example, when we eat, our dopamine levels go up. We drink, dopamine levels go up. Sex increases dopamine levels. Crack cocaine increases dopamine levels fourfold. So, and that stimulates brain's pleasure and reward center. So when the brain's pleasure and reward center gets used to that boost of dopamine, it continues to crave it. So that takes me to the second question, why some of us develop it, some of us don't. So that's genetics. To some degree, there are two factors that play a role, genetics and access. So we got multiple other factors also play a role, but genetics. Genetics play a big role in why some of us have the propensity to, once we discover something that feels good, to keep doing it. Some of us may not care for it as much. So that has been with us for ages and ages and ages. Addiction medicine has evolved, say, over the last 20, 30 years. Do you agree, Sarpolis?
I would say about that length of time, yeah.
When did ASAM take? Do you know roughly? I was trying to remember how long ASAM, American Society of Addiction Medicine, has been in place.
I think the 1960s. I mean, following, the development of methadone, I think, is around when the time ASAM came into being. Yeah.
And so as an organization, as a society trying to organize as physicians who are interested in addiction medicine, American Society of Addiction Medicine was formed. Prior to that, we didn't have any. For example, like we have American Board of Neurology, Surgery, Internal Medicine. Prior to that, there was nothing referred to as addiction medicine. It wasn't even a specialty, it wasn't even recognized. So ASAM got the start. Now, going back to history of treatment, the first person that actually started writing in medical field that alcohol causes alcoholism, you all will say, duh, you know that now. But it was actually to document it was Rush. I think it was 1782 that he described it in a scientific paper. And he really actually described all the symptoms of alcoholism that we know now. The first group that started the treatment here in U.S. Was Asylum in New York. That they call it Asylum for Inebriates. They call it inebriation back then. And their belief was patients need to be removed from their environment and be treated. And they had their own security. If someone ran away, they used to send the security after him, and they'll grab him and bring it back.
We don't do that anyway. Okay, just so you know that. We're not a lockdown facility. We're not sending you to the alcohol after you.
So that model continued for a while. Then a physician with the name of was called the Leahy group started their own set of treatments. But actually some of the basics today they incorporate still comes from the Leahy group, such as camaraderie, help, going to meetings, being involved, doing some service work. However, they started going into using some medications that were not approved, such as gold bicarbonate, injecting it into patients, and that's when the federal government kind of stepped in, realizing that we just cannot use anything just because one says so. And the Harrison Act started, and after that, I think Salvation Army started some treatment centers. It still is one of the largest treatment providers in the world. And fast forward a few years, then AA started by two fellows who were in recovery, or they're trying to not to drink. They met accidentally in a meeting, and they started talking to each other, and that actually helped both of them. Bill W. was one of them. Uh, that started AA. That was the beginning of AA. A few years later, I believe it was in 1945, Hazelden started with a different model, which was incorporating patients into a milieu. And that was the first model, still referred to it as Minnesota model, that desire to stop drinking or stop, back then it was drinking, is not up to the patients, it is up to the milieu. So that was a very different approach that as treatment, we have to actually spark that desire for them to stop using. And over the years, it continued to evolve with different models. Up until most recent years that we started utilizing some medications to help patients. Now, many treatment facilities now use a combination of the recovery, the 12-step recovery, the milieu model, a little bit of both, including the medications. Dr. Sarpolis, would you like to add something further to this history?
Yes, that's perfect. I was going to ask you to start with the medication.
Well, and then come along the medications. I mean, the first medication that we really had, I'm aware of, was methadone. Methadone clinics that came into being some years ago was our first method of treating. It's basically a replacement therapy. You're using what's called a full agonist opioid. What you mean by that is something that fully engages the opioid receptor and then turns on the mechanism of the cell that creates the sensation or euphoria that you get from opioids. So methadone was really just a long-acting drug that you could dose once a day. So you could have a patient come to a clinic on a daily basis, usually a dose in a liquid form, swallow their medication under observation, and then go home, come back and get another dose the next day. As far as I know, it's still performed in the same manner. We don't have methadone in our armamentarium at Gateway. We don't have methadone certification to dispense that medication right now. It takes a lot of regulatory hoops to be able to dispense methadone. And instead, we've been using Suboxone. Suboxone was the more later created. It was probably about 20 years ago now. Yeah, 20 years ago, Suboxone came into being. And Suboxone has some very unique properties to it. It's an opioid. It can be used as a pain medication. In fact, it's marketed under different names as an analgesic medication, like you would take Norco or Percocet or Oxycodone or whatever. But what's unique about it is it kind of engages the receptor, it latches on tightly, so it's got a lot of, what's the word I'm looking for?
Affinity.
Affinity to the receptor. And it gives a partial response. So it doesn't make patients high, but it alleviates or keeps them from going into withdrawal. Because obviously, if you stop your opioid, you build tolerance over time, you get this horrible withdrawal. So people get nauseous, throw up, they get sweats, they got body aches all over. They just feel miserable when they're withdrawing off their opioid. So Suboxone was created, and it's one of the reasons that I really got into this field. I think the government's initial idea for Suboxone was that primary care doctors were going to be dispensing his patients in their offices, which I think is pure fantasy. It really takes a lot of experience in using these medications and treating these people, and they need so many other facets of treatment that it's hard for a primary care physician to coordinate all that. And that's the struggle I had. I had patients when I was working for Gateway, and believe it or not, the first way I ever heard about Suboxone was on NPR. I didn't read it in Journal. I've got to say that the internal medicine, kind of the medical literature, is rather bereft of much in the way of substance use, sort of literature. So you don't learn a lot when you're a primary care physician, frankly, about these treatments.
Sarpolis, NPR is better than TikTok.
So- That's a good-
I get all that.
That's a good point though, because I think one of the things that now in the last maybe 10 to 15 years, as we try to work against the stigma, is integrating behavioral health in primary care. So I think advocates in our field are working towards that, but still our primary care physicians are either not knowledgeable, there's a lot of fear, there's a lot of ignorance, and it's also why people forget that addiction is a chronic disease. It should be treated as a chronic disease because you're gonna live in long-term recovery for the rest of your life, but it's not going away per se, right? So it's making that shift from somebody who lives with diabetes and has to monitor it with medication every day to somebody who's living in a life of recovery. So let me ask you, what is the difference between, and we talked about, this is about medication-assisted treatment, which we now are trying to say medication-assisted recovery for that precise reason, that we want people to understand that being a part, that this is part of their treatment every day. What is the difference between the medications you just talked about and Narcan or Vivitrol or some of the other medications that people talk about?
So let me actually give you a quick overview on what these concepts are. Full agonist, antagonist, partial agonist. So three concepts. So what's a full agonist? Full agonist is a substance that fully activates the receptor. Think of driving. If you get behind the car, step on the gas, pedal to the middle, go take off going 100 miles an hour. That's a full agonist. That's what dopamine does. That's what opiates do. Heroin, morphine, codeine, oxycodone. They're full agonists. Now, if you take your foot off the gas pedal, car stops. That's an antagonist. It's something that blocks that receptor. What do we do if you're driving 30 miles an hour? We push a little. So that's a partial agonist. And there's a rate limiter with a partial agonist. Remember the cars we used to drive in the amusement parks when we were little? It didn't matter how much more you push, it didn't go more than 5 miles an hour. That's a partial agonist. So the difference is opiates, heroin, morphine, codeine, oxycodone, codeine are all full agonists. Narcan, that you will get a little hands-on experience with, is an antagonist that blocks these receptors. What is buprenorphine or Suboxone or its various names that it comes under? It's a partial agonist. It hits that receptor, but there is a rate limiter. And that's why FDA finally approved that for office-based treatment versus methadone. Methadone is a full agonist, which means if someone takes too much methadone, they'll go into respiratory depression and they die. It also has a buzz effect, so it has abuse potential, diversion potential, and deadly. Versus with a partial agonist, there is a ceiling effect. So it doesn't matter how much they take, they cannot kill themselves. So that was the principle behind approval by FDA for office-based use, rather than a federally monitored, very tightly monitored methadone program. Going back to what you, the question that you asked is about the disease process, why medications? So it took us a while to figure out that with some addictions, actually with most addictions, replacement therapy is very effective. And the first evidence of this was methadone, actually. We took patients off heroin, gave them methadone. And the ones who really adhered, along with other support services, they tend to stay off their drugs. So that was one of the initial evidence that replacement therapy can help. But we were very limited. We still are limited. We don't have replacement therapy for stimulants, we don't have replacement therapy for cocaine, and many other drugs. But for opiates, which actually lead to so many deaths and a significant amount of medical burden, methadone was the first one, then buprenorphine was the second one that was available to us, so at least we can have patients on a medication to prevent their withdrawals, keep them stable, give them a chance in recovery. Let them work on the rest of the psychosocial interventions that they need to remain off their drugs. So that's what started the whole concept of medication-assisted treatment. And it's not limited to just methadone and Suboxone, and the other one is naltrexone. Now, it comes in the oral tablets, the monthly injectable version. Now, what is naltrexone? Naltrexone is an antagonist. So when patients have that in their system, if they use, it's not going to work because they have a blocker blocking the immune receptors in the brain. So these are some of the medications that are available to us to help our patients to remain in recovery. Anything you would like to add, Dr. Sarpolis?
Just in terms of, Suboxone, or the generic name for it is buprenorphine, actually. You have to give it, it's very safe in opioid dependent patients. Okay, so if you've got somebody that's been using heroin in significant amounts for months, it's a very, very safe drug. If you or I took it in the usual dose, it could potentially kill you. So it has to get to the issue of tolerance. You're building up that tolerance. You're probably getting more of these receptors on the cell surface as you're stimulating them. And if you don't have that receptor buildup and you get that sudden dose of a relatively potent opioid, you could have serious effects.
Good point. Very good point.
So I think the more, especially after COVID, the more people have gotten used to, I can just access treatment virtually. I can just go once a week and get my medication, and I'll be fine, and I don't really need anything else. So that is a concern, I think, for those of us who are advocates in the field, to try to educate people that if you have been using substances for a long time, you're going to need more than that. So talk a little, whoever wants to talk about sort of your person-centered medical plan. How do you determine what the right dose is, what it is that people need? Like, would you recommend medication-assisted treatment for everyone? What is the right way to make sure that people don't just think, I can just go to an OTP, which is an opiate treatment, outpatient opiate treatment clinic, and that's going to be enough for me to be able to live a life of long-term recovery?
The medications alone rarely suffice. They're a tool that we have. It's an adjunct, but they're not a perfect tool by any means. And I can speak from a lot of experience because doing as a primary care physician, prescribing Suboxone patients was always very challenging for me. Again, it was part of it was getting the counseling piece, and you have to have special training for dispensation of Suboxone. By the way, not every physician can just write a script for it. You have to take a relatively brief course, but you have to have some certification to prescribe the medication. There was always a difficulty in coordinating that counseling piece with dispensing the medication, trying to get people hooked up into effective counseling at the same time. That's the thing that always I loved about Gateway. I mean, we kind of got it all. We're giving the medication, we have the full range of outpatient services at various levels, so patients can be constantly engaged in both. And all the studies showed that the combination of the two of them was effective. If you just do one or the other, if you're just doing counseling alone, or if you're just doing medication, you have less of a success rate in keeping people sober, basically. So that was always the difficulty on that side. In residential treatment, okay, if you talk about what you're trying to do in terms of selecting medications, you may feel different about this, but the choices we have for, if we just talk about opioids, so we basically have that naltrexone, Vivitrol, which are the opioid antagonists, Suboxone or methadone. Okay, and basically my choices between, or the patient's choice, I should say, is between Suboxone and Vivitrol. So the statistics are fairly comparable for success in both of those. Vivitrol's a little bit worse, but what we're often doing is we get people into treatment, we stabilize them with Suboxone. I like to let them have a few days on a full dose of Suboxone and say, how's it feel? And then talk about their other choice, and then talk about the fact that they would then have to taper off of the Suboxone and then start on a drug like Vivitrol or naltrexone. It's a little complicated, but we can accomplish that when they're in residential treatment.
You mentioned about the approaches of how do we decide. Does everyone need medication? Yeah, it's complicated. The factors we usually take into consideration is age of the patient, duration of use, amount of use, type of the drug they're using, prior attempts at recovery, complications of the use. Medical comorbidities, psychiatric comorbidities. So you have to take all of that into consideration to figure out what serves them best. Of course, everyone starts with a detox process. We have to slowly get weaned off, utilizing whatever is available to us. And I'm going to include alcohol in this also. Many don't realize actually alcohol withdrawal can be deadly. It's very dangerous. So many patients try on their own to just stop, and they have seizures, they have DTs, and a lot of horrible things that happen to them. So first it starts with detoxing it, getting them off their whatever they were using safely. Then how are we going to maintain it? Is the maintenance going to be using a partial agonist such as buprenorphine or buprenorphine product or Suboxone? Or if the patient is young enough, their duration of use hasn't been that much, they have the support system, they have the motivation to remain off the drugs, maybe we'll just use that buprenorphine for a while, get them off, maybe get them on Vivitrol, monthly injections for a while. And if they slip and use, it's not going to work, and they cannot overdose themselves on it, usually. So that all of those we take all of that into consideration. Versus a patient who's been using heroin for 30 years, maybe that's not a candidate. That becomes more of a candidate for continued maintenance on a buprenorphine or methadone program.
Yeah, that's very good. And I think, I asked the question because I think people think, oh, well, I'll just take this medication forever and I'll be okay, right? Which is definitely not the case. So at Gateway, we do addiction medicine, but we also support 12-step and community. So talk about that as part of the treatment planning for patients.
So research shows actually one of the most effective interventions is AA, meeting attendance. So if someone starts even doing a little service work, as simple as picking up the coffee cups at the end of it, the chances of remaining in sobriety long term is even higher. So it really helps because it is just not going to a meeting. If you've ever looked at 12 steps, I always say, the world will be a better place if all of us did step one. And it's all about self-learning, learning how to deal with life, learning to deal with life in life's terms, coping skills, some basic measures, and a lot of things that is utilized in AA has daily applications, such as stay away from people, places, and things, limit your access. And how do we deal with stressors that comes to us on a daily basis in life? And that support tends to really be helpful. However, people have different approaches. They have some refer to AA as being very religious per se or spiritual. Then there are other means such as rational recovery, smart recovery. We encourage them to attend what works for them. And, however they want. It is about investment in their own recovery. So for many patients, actually, even before that can be helpful, they are struggling with a lot of anxiety, depression, post-traumatic stress disorder. Trauma is very common in the addiction world. And those also need to be addressed through individual therapy, group therapy, medications that they may need. So that's why just going and taking Suboxone is not going to really work if you're not addressing the rest.
So I was going to say that one of the most common stories I get, people coming in, because we do get a lot of return business, unfortunately. We get people that relapse. We suspect it. There's some acceptance, maybe acceptance is not the right word, but there's some expectation, I think, that people do relapse. This is a chronic disease where people fluctuate in terms of where they're at. You have long periods of sobriety and then relapse. But the common story that I hear from patients coming back in after being successful for some period of time is, oh, I was going to groups, I was attending AA, and then I just stopped going for some reason, and 3 months later I started drinking or I started using my heroin again. So it kind of emphasizes the importance of that ongoing social activity, whether it's an AA or some other form of counseling. It seems to be very important in maintaining sobriety.
And that's also why Gateway really, when people come to us, we say we want to be your partner for a life of long-term recovery. So you come to residential, you step down to outpatient, and then we support you through our virtual and in-person long-term recovery, because addiction is a disease of isolation, right? That's why the group and the community is so important. So any questions from all of you?
I'll ask a question, and I'm not a plan for questions.
No, you're not. Good job.
We've come a long way with the acceptance of Narcan. Let's not get into that, but we're going to see some of that later. As physicians, what would you say to the many physicians that are watching here tonight, who work in an emergency room setting or an outpatient clinic or an FQHC, who don't yet see a person in a substance use crisis? They don't see that person in the same level of crisis as we would see someone coming in with a chest pain or a shotgun or something other, some other situation where their life is in danger. How do we raise the awareness so that they see substance crisis also as life threatening?
That's a great question. You actually touched upon what has been missing in medical education. And it is still going to require a lot of more awareness programs, CME programs, emphasis, residency trainings focusing on substance use. Because one of the issues that actually has led to this has been, I call it learned helplessness, because of lack of resources, lack of knowledge, propensity to diagnose is going down. Because if I diagnose something, then I have a disease or whatever, I have to do something. But they can diagnose, but they have no resources, no place to send them to get them the help that they need. And that has actually resulted in them kind of closing their eyes and, okay, this is not that serious. We'll deal with the cut or whatever. They roll down the stairs because they were drunk, so they'll just fix up their broken leg and forget about the real reason why they fell down the stairs. It is going to require more education, in my belief, during medical school residency and more resources. We really need more resources for treatment, so we're able to refer patients to treatment once we identify an issue. Dr. Sarpolis, your thoughts?
Yeah, in terms of Narcan, I often forget, when we're dealing in the acute situation, we got people coming into treatments, you're not always in the thought process of thinking about when they're going to discharge. I got to say that it's mainly our nurses that have been very good about this. It's almost in the admission orders. So when we're admitting somebody with an opioid issue, in goes the Narcan, yes, the initial drug, so it's going to be on site when they discharge. Whenever that happens, some of them leave early from treatment, we have it on site and they take it with them. So that's, I think we've been very active in terms of trying to dispense that product into the community.
So I think, Elliot, though, your question really, I was asked this question by an elected official down in Springfield during a hearing, because it was, well, you keep saving the life, and then they keep coming back and doing it again and doing it again. And so, and it was a good question. And I said, well, at least then there's a life for me to save. If I don't save it, there's no life for me to save, right? And then again, if you equate it to other issues, and people make bad decisions all the time, and we don't punish them for them, right? We give them help. So, but it's a great question, and I think it goes to the punitive nature of saying you have a choice, and we, the Gateway, we say it's not, we no longer say what is your drug of choice, right? That's the way we used to do it, or here's your brain, here's the egg, here's your brain on drugs and all that. That was the old way. Right now, we're saying this is a disease, we understand you have a disease, and we're here to help you. And if you are dead, then we can't help you. So this is why we need to say that.
So you actually touched upon I would like to talk about accepting that. Alan Leshner was the director of NIDA in 1980s. He was the first one to actually publish a paper saying that this is a brain disease, this is a disease. And we know it is a disease. It is a chronic disease. However, again, goes back to need for more education in the medical setting to deal with it, such as chronic disease. And I always give this as an example. If you have a patient with diabetes that happens to end up in the ER in decay, with elevated blood glucose levels, everyone gets on that patient, takes care of them, they readjust their medication, redo the diabetes education, maybe set them up with a home health nurse to follow up to make sure that this doesn't happen again. A patient who relapses and ends up in the ER with overdose, not the same approach.
Now, we have our partnership in 26 hospitals, which we are doing, and today I was at a hospital all the way on the burbs, and it was the nurses who said we need more education. The nurses also, not the doctor, right? The nurses are like, we send these people home, we don't know what to do. Gina, were you gonna ask a question?
No, I was taking a picture.
Oh, okay.
I was just
Yeah,
gonna
so-
say, Teresa, that one of the best things we have at Gateway, I think, is our outreach program in the hospitals, where we have people in the hospitals engaging these patients when they come in. And it stops that revolving door, because it's not too uncommon to hear of a patient, who I saw last week, who had been into detox, into the hospital like 4 times within 3 months. And they get detox services for 3 or 4 days, they don't get any follow-up, any referral, and they go back to drinking. And it's rinse and repeat. It just keeps going around until somebody breaks that cycle and gets them into treatment. That program has been very vital to us in getting people into treatment in a timely manner at that point of crisis.
Yes, absolutely. Thank you, and I can share more about that. Jerry, were you gonna ask something?
Oh, I was just gonna say how frustrating it is, because I've heard this conversation for many, many years about how this education is needed. And is it foundations like Gateway that are coming in and finally saying to people, this is a disease, or to the doctors or law enforcement for that matter? It just, it's kind of like, come on, it's 2022 and we're still there. So I was just wondering how.
Yeah, I mean,
to implement it.
I think we are a treatment provider, but we're definitely an advocacy organization. A lot of, my role is to do that. And I think as a community of providers, we try to do that, but there's still a long way to go, right? It's really the nurse preparation programs, the physician preparation programs, and even the counselors, even if we think about the schools, it's a lot of professional preparation and kind of taking the fear and the ignorance away from the disease.
Yeah, there's a lot of investment in it, not only us, but other organizations who are working in this field. We continue to be very vocal. I don't shy away from providing grand rounds at any hospital that would like to hear it very actively to educate other physicians and their medical staff about what addiction is, how do we treat it, giving a little background about Gateway, so what we do and what are our services that we can provide for them. But it's been slow to move the needle. It's moving. When I look at just my own experience from today to 20 years, 25 years ago, the needle is moved. There's more awareness. There's way more awareness than 25 years ago. But unfortunately, it's moving very slow.
And denial's a big
Denial's
problem.
Yes.
Yeah, thank you guys. It's been great so far. Sorry if I missed this, but what exactly does the medicine do for people who are addicted? Like how? Yeah.
So what does medication do? One, medications reduce the chances of withdrawal, depending on the type of medication you're using. so they don't go through the severe physical withdrawal that coming off a lot of substances are associated with, alcohol and opiates being on top. 2, reduces their craving for it, and that's the big one. Because if you can reduce the craving, then it's better chance of being able to adhere to a program. If there's constant craving, and the best way to describe craving is there's a part of the brain, and we're still again learning more about the addiction circuitry in the brain. For years we knew about the reward and pleasure center of the brain. There's another part in the brain called insula. So what does insula do? And that's quite active in addiction. I'll give you an example. Say we're all in this setting and you may have an itch on the back of your leg. And you may feel it's not appropriate for me to scratch it. But the itch is there. You're aware of it, it's there. You wait till you are someplace that you're away and then you scratch it. So with addiction, that itching, that's the insula part of the brain. It's always there, always there, always there. So having them on medication can potentially dampen that, so they can actually remain focused on other services that they need. So that's what meds do.
Thank you.
Well, thank you. I think we're gonna do the Narcan demonstration now. So I'm gonna switch roles with Deirdre. So I have to leave you all.
Okay.
Teresa, thank you so much
Oh, of
for
course.
moderating today.
Yes,
Greatly
thank you.
appreciate it.
Thanks.
And thank you for all your efforts with our hospital outreach program. So Dr. Garate has been instrumental in setting that up. As I said, 26 hospitals.
Yes.
Thank you. I missed the last 2.
Thank you.
Any other questions?
I got one. So you guys mentioned earlier that there's a high incidence of psychiatric comorbidities with substance abuse disorders. And I know that the symptoms of those two things can overlap and exacerbate each other. Does that create any sort of one diagnostic challenges, and also do you find that treatment of one is plays a key part in the treatment of the other, vice versa?
The short answer is yes, yes, yes.
Okay.
That is true. The diagnostic challenge is huge. Because a lot of times, for example, you see a patient in front of you with significant mood issues. Now, is this a drug-induced mood disorder? Or is this a primary mood disorder that's been exacerbated by the drug and alcohol use? So that's always a challenge. The old approach was by American Psychiatric Association that one needs to stay off their drugs and alcohol for about a year before we can accurately diagnose their psychiatric issues. I had an issue with that for the last 25 years and didn't adhere to that. Because in my belief, it's naive to take someone from the drugs and alcohol and anticipate that they're going to stay fine and dandy. So our approach, and my approach has been, let's treat both concomitantly, aggressively, till we know. Now, once someone has been in recovery for 2 years, then we have a better idea of what else has been going on. But at the point, if they are depressed, if they're anxious, if they're manic, we still need to treat those.
Gotcha.
Not to generalize, but every patient that seems to come into one of our residential facilities has a diagnosis of depression and anxiety disorder.
Right.
Whether those are always true, you don't know until you get the drug out of their system and really
Right.
see how they're behaving. So, that's the one thing, we kind of get a detox and have psychiatry see them once they're out of that detox phase. And a lot of times, a lot of those symptoms go away. Not always, but that's the advantage of having people in a residential program for some period of time, and so we have some time to analyze the complexity of what's going on between the drugs and maybe other psychiatric illness.
Okay. You mentioned spiritual aspect of drug use, things like that. What's your thoughts on microdosing, ashgan weed, and DMT?
This being studied. Microdosing, psilocybin is being studied right now for treatment of anxiety and depression. So let's see what what I call randomized clinical trials show, because that is the highest evidence of scientific evidence. And what I mean by that is scientific evidence goes in levels. The lowest level is what we call anecdotal. Anecdote means I can tell you, hey, there's this one guy, I gave him aspirin and it worked for him. And I say, okay, I guess aspirin is good. That's anecdote. Then the second level up we refer to as open label trials. So we take 100 people, give them all aspirin, and then see what happens to this. If 60 of them did okay, then say, okay, in this open label trial, aspirin works. Then the highest level of scientific evidence, and that's what FDA requires, is approval of a lot of medications that we're using, is double-blind, randomized, placebo-controlled trials. So you take 100 people, give them aspirin, another 100 you give them placebo. Follow them for say 4 weeks, 6 weeks, and see what the outcome is. So based on that, we can tell if it's, and on that one trial, at least 2 positive trials. So let's see what the trials show. But right now, as kind of a fad, everyone is microdosing, everyone is doing that. It's anecdotal. It's, yeah, I mean, if you look at the hallucinogenics, they exert their effect through a serotonin boost. So any serotonin boost is okay for a while, but how long does it last? How much of it do we need? What are the adverse effects? What's the long-term potential of that is going to be? We don't know. So I stick to our FDA-approved, double-blind, randomized, placebo-controlled trials for now.
The Michael Pollan documentary is interesting.
It's definitely growing population.
Did you have a question? So we're going to wrap up this evening with an example of Narcan going to all of you. And did you discuss who is going to just demonstrate how it works more or less?
I'll leave this to Dr. Sarpolis. He's our
Okay.
expert on this.
Getting the box open is the
I would
biggest
volunteer to
challenge.
receive a dose, but
It's very simple device.
so Narcan is an antagonist. It reverses opiate overdose. And if you've ever used it or seen it used, it's a miracle. You go from patient, there you go.
Put
So,
it in the nose. And that's it.
Good.
Just push the button. Get a little Narcan up your nose.
And just have one side,
that's
each
one
dose
dose.
is-
That's one dose. Yeah.
And can you describe situations where you might use this on another person?
Well, obviously,
When would you know the moment? Or
obviously anybody unresponsive. I mean, very often, you know, in the field, I mean, just about anybody. I mean, we're running into circumstances in the residential unit where we've had people become hypoglycemic, for instance. But, you know, the first reaction with anybody who we find unresponsive is to give them Narcan. It's the first thing we do. Usually at the same time, the nurse is checking their blood sugar, getting the blood pressure, and checking other vital signs at the same time. Anybody that we find that's unresponsive, administer this to as a first step.
So let me ask. Yeah.
I'll get a question planned because I know the answer, but I think this is an important one, especially for people that have kids at home. Would anything bad happen, like your kid found your Narcan that you got and opened it and put it up their nose or put it in their mouth?
does it pose a danger if a child were to?
That's a good question. I was actually going to ask Dr. Sarpolis the same question. Can you do harm with Narcan? No.
Is it expired?
Pretty innocuous drug.
No.
Does it expire?
Yeah, they have expiration date on it, and that's part of what we do at Gateway. We routinely check for expiration dates. You always have the ones that are not expired, but you really can't do any harm. And going back to if you find someone unresponsive, that could be should be the first step in case they overdose.
Did you have a follow-up?
I do. Another planted question is, let's say you do one dose and the person still doesn't come to, and you don't know if there's any other medical stuff going on. Would anything happen if you gave them another dose or a third one?
So, as a matter of fact, there was a lot of our overdoses over the last few years has happened because of synthetic fentanyl. U.S. government finally cracked down on China, and they actually outlawed fentanyl labs. So, what they did, they went to producing another compound goes by iso. It's another synthetic opiate. Usually not detected in regular toxicology, has a longer half-life, and it needs more than one dose of Narcan to turn patients around. So It doesn't hurt. You do one, not much, you do second one.
So each box you'll get tonight, there's 2 doses in each box. Gina, did you have a question?
Yeah, do they, like, do a lot of schools and police officers, do they typically carry Narcan? Is that like a drug that a lot of,
I believe they are now.
yeah.
Now, before it was just the emergency personnel, but now the police officers all have Narcan.
Shane?
I was just gonna say, the Chicago Public Libraries hand out Narcan free of charge at all the Chicago Public Libraries, so.
Actually, the DuPage County Health Department just started installing vending machines with free Narcan around the county out in DuPage.
Carolina, is it also true that someone can go to a Walgreens, or can you get 1 dose from a
Yeah,
pharmacy?
there's a state, well, I'm sure Dr. Rafeyan knows, but there's a standing order in the state of Illinois, so you don't actually have to have a prescription.
Would you equate it to keeping an EpiPen? Just have it as sort
Yeah,
of
I think
is that an analogy that people
pretty
can
much
understand?
very comparable to that, you know, I mean, obviously it's a, you know, for somebody who's opioid, who's had that history, yeah, you would carry your Narcan around just like we would if you were, you know, allergic to disease, carrying an EpiPen, yeah.
I would actually take it a little further. Would it hurt if you have one in your car? In case, same thing as EpiPen, you may have one in your car and the friends got an allergic reaction, you think they don't have it, you have it, lifesaver, same thing.
Yeah, construction job sites and our safety kits, they're starting, depends on Narcan.
Okay.
That's great. Any final questions before we wrap up for this evening?
I have one question. But basically, when you're walking down the street, I see someone on the ground. As a layperson, how do I know that person may be a candidate for Narcan, or if that person is sleeping, or having another issue that's not related to substance use?
Having just gone through my basic life support day, I mean, it's basically the same technique. You find somebody that's unresponsive, you shake them first, check for a pulse, you know, see if they have a pulse, try to get an idea if they're breathing or not. You go through all those stages of trying to establish whether they're in cardiovascular or respiratory arrest, okay, to try to get an idea what the problem is. But there's always going to be no harm, you know, depending on the situation and dosing that person with Narcan. If they're without vital signs, then you have to start CPR, you know, but you still give Narcan at the same time. And if you had, which rarely you're going to have, some form of glucose to administer, that would be the other thing possibly to get an acute situation like that.
But again, if Narcan is administered, it can't cause any harm, or it should not.
That doesn't cause any.
So we're going to close out this evening again. We'd like to thank Dr. Sarpolis, Gateway's physician at Independence in Lake Villa, and Dr. Rafeyan,
It's been a pleasure, thank you.
Gateway's chief medical officer. And Gateway would like to thank again Jerry and Jack Kelly and all of the folks at MKB Architecture Studios who are doing beautiful trauma-informed design work for Gateway. And we would also like to thank our Young Professional Board, which is chaired by Gina Sokami, who is here, and we are hoping to grow our Young Professionals Board. So please go to our website to Giving at Gateway if you would like to become supportive in any way as a volunteer, a Young Professional Board member, or a donor to support work that we do. Vital work in the United States, across Illinois, and in some other states is where Gateway is, giving effective substance use treatment. Thank you, and we wish you a very safe and healthy September Recovery Awareness Month. Good night.
Thank you. Thank you.